Oh, Maima, I think you're still muted.
Oh, thank you. Hello, everyone. Happy Monday. Thank you so much for joining us for another Rafael Medina Subspecialty VMR. We have such a big crowd today. My name is Umayma. I'm CP Solvers team member from Morocco, and I will be facilitating. Today's focus will be pulmonary and critical care medicine, and we are joined by two wonderful guests. We have Dr. Hassan Bencheqroun here as a case discussant, and Dr. Anna Fretz as our case presenter. Dr. Bencheqroun is a pulmonary and critical care medicine specialist in California, native of Morocco. He is the medical director and CEO of Respire Clinic and Research, where his goal is to bring state-of-the-art medications to communities and bridge the gap between them and between medications currently in practice. He also holds a clinical assistant professor faculty appointment at the University of California at Riverside. His commitment to his patients and to medical education was exemplified through multiple awards, like the Medical Education Award and the Patient Choice Award that he got multiple times. Thank you so much for joining us, Dr. Bencheqroun. And we also have Dr. Fretz. Dr. Fretz is a CP Solvers team member. She is originally from British Columbia, Canada. She completed her medical residency at UCSF, and she's doing her chief year at UCSF as well, and will be starting her PCCM fellowship at UCLA. Thank you so much for joining us. We are so proud and grateful to have you with us today. And before we start discussing the case, I would love to turn the mic to you to learn more about why you chose pulmonary and critical care as a subspecialty, and maybe something fun that you did this weekend.
Hello, everybody. It's a pleasure to be here. And why I chose my specialty, because we rock. Initially, in Morocco, well, in Arabic, the name doctor is stated as Al-Hakim, which is the all-knowing and wise. So I kind of grew up with thinking that I needed to know everything about everything if I wanted to help my fellow human being. And the closest to that was critical care. And then pulmonary and critical care, mostly because it's pretty physiologic. And it gives me a superpower that is either I can make people breathe better or I can take their breath away, one way or the other. So I get to choose. Dr. Fretz?
That is very inspiring as someone who is a future critical care doctor. I chose pulmonary critical care medicine because I love general medicine, but I like sick patients. And I felt like critical care medicine was a really nice kind of way to encompass both of those things, like being a whole body doctor, but doing it in very extreme circumstances. And I also am really interested in end-of-life care, which is sometimes the case when people are critically ill. And so it also appeals to that interest. Something fun I did this weekend, I was babysitting or dog sitting one of my friend's dogs who likes to play with my dog. And so I basically just got to watch dogs play, which is one of my hobbies. Yeah, I'm really excited to be here.
Thank you.
I love this.
I missed the second part of the question. What did I do for fun? Now I'm jealous, but I think I can one up that by saying this past Saturday, my niece, she's 10 years old, and she has a end of year class dance, and it's masquerade themed. So she calls her uncle and panicking, nobody would tell me what this is. I have no idea what to expect. Plus my mom won't let me go. And I'm a twin, so I'm known I'm the only one who can influence my sister, her mother. So I actually took her out dress shopping. And so we went purse shopping, shoe shopping, dress shopping, bolero, necklace, pearl necklace, pearl bracelet. So she has the whole thing. And now this coming Saturday, I convinced my sister that I could take her if I could be her date. She says she's too young to have a boyfriend, so I'm going to be her date. And the only thing missing is I need to teach her a few steps of dance.
That sounds so fun. Very sweet.
It is. Thank you so much for sharing these beautiful memories with us. Now, once our scribe is ready and the screen is good to go, you can go ahead and present the first aliquot, Dr. Fritz.
Absolutely. And please call me Anna. I'll never quite get used to that. So this is a 76-year-old woman who has a history of hypertension and diabetes, who is presenting after feeling short of breath at home. And she called EMS or 911, emergency services. When EMS had arrived, the patient was noted to have an oxygen saturation of 70% on room air. So she was placed on a non-rebreather. She was brought into the hospital via ambulance. But while she was en route to the hospital, she actually experienced cardiac arrest. They initiated chest compressions and noted on the monitor that she was in sinus tachycardia. She underwent 5 rounds of CPR with 3 of epi that had been administered, and subsequently had ROSC, or return of spontaneous circulation. And she had an oral airway that was established during her arrest. I'm going to tell you about her exam. That's like literally all I knew about this left side of the screen. I'm going to tell you about her exam when I met her. So when she arrived in the emergency department, her blood pressure was 82/60. Her heart rate was 118, and she was saturating 95%. Her pupils were dilated and sluggish, but still reactive. Her cardiac exam was tachycardic but regular. And she had bilateral breath sounds, but they were very roncorous. And then her belly was soft and non-tender. Her extremities were cool, and she had trace lower extremity edema. And then other notable things from a neurologic exam is that she had a cough, but no gag, and she was withdrawing in all 4 extremities. And you couldn't get her to kind of do anything otherwise. She did have a fast exam in the emergency department that was negative. That's for like looking for any like fluid collections. And then her IVC was noted to be enlarged. It was 2.3 centimeters. It collapsed less than 50%. And we were not able to get good cardiac windows. She had an EKG that showed a right bundle and sinus tachycardia. And then basic labs for her, CBC showed a white count of 16 with a left shift. It was otherwise normal. And then a BMP showed a bicarbonate of 12 and a creatinine of 1.8 from a baseline of 0.7. And then she also had an ABG that was 7.1, 82, and 79 on 100%. And then her lactate was 9. And that is the information I had.
Thank you, Anna. That was a very busy first aliquot so far. Dr. Bencheqroun, before we go into the case, can you tell us what are your first steps when you're evaluating a patient who has arrested outside of the hospital?
Thank you. Unfortunately, that is actually quite frequent scenario that we get. When I hear about a cardiac arrest, before I go into anything else, two things come to mind. You said out of hospital, that's important. It's an out of hospital cardiac arrest. And what is the primary rhythm? And the primary rhythm is a sinus tachycardia, but no pulse. So it's a PEA. We want to also know what is the time to CPR, quality CPR, whether there was any bystander CPR or not. It seems to be immediate, and bystander CPR was with EMS, which is qualified. So there was no downtime before CPR. And then what is the time up to ROSC? And so if we are saying 5 rounds of epi, well, 3 rounds of epi, I believe is what was said. So epi is given every 3 minutes, so that's about 9 minutes. So we can say that she had 9 minutes to ROSC. And so those are things that determine the outcome of an out of hospital cardiac arrest. Similarly, I want to know the patient's neurological status, because clearly we will be talking about targeted temperature management, and targeted temperature management has its contraindications. And the contraindications typically involve patients that are now awake and responsive, or the complete opposite, patients that are moribund and not quite unstable, maybe 2 or 3 cardiac arrests back to back, or patient with no very poor prognosis of survival. So those are things I look at, and this patient does have some response. Pupils are reactive, and she still has some breathing of her own. So the brain stem still has some function. And if we can obtain some understanding of why the patient had a cardiac arrest, which the labs are presented, the white blood cell count on admission at a cardiac arrest is very difficult to interpret. It could be contraction, leukocytosis from a patient who was in extremis. It could also be that the white blood cell count is from septic shocks, as stated. Therefore, septic shock could be leading the cardiac arrest. The lactic acid is 9, but that's expected to be found. So we don't know if it's chicken or the egg. Is the lactic acid causing the acidosis that caused the cardiac arrest? Or is the lactic acid consequence to the tissue dysoxia and the anaerobic metabolism that happened, which caused the cardiac arrest? Only time will tell us. And then lastly, if there are any comorbidities that I would need to know, such as that they had, my cardiac arrest last night was somebody who was living with the condition of idiopathic pulmonary fibrosis. So that poses a bit of prognostication right there. This woman did not have anything at least known other than diabetes and hypertension. So it doesn't lead us towards anything specific. So all I know, the way I would present this is 76-year-old with hypertension and diabetes presenting with an out of hospital cardiac arrest, primary rhythm, PEA/sinus tach, and downtime is 9 minutes till ROSC with immediate quality CPR initiated, some brainstem response, and leukocytosis with metabolic acidosis. So that's the way I'm thinking about the case so far.
Yeah, thank you so much, Dr. B. But before we move on, and for the students listening, could you tell us how you would interpret the POCUS findings for the IVC and the IVC of 2.3, and whether we can tie this with the physical exam findings?
Good question. So when we started to do POCUS, which is point of care ultrasound, there are many things that we are now trying to establish as part of the clinical exam. In fact, the POCUS now is called the new stethoscope, and that is because it is an extension of our physical examination. So the IVC diameter, as well as the collapsibility of the IVC, and that is standing for the inferior vena cava. The ultrasound is taken from the subxiphoid or from the mid-axillary right-sided window to show whether the IVC is plump or the IVC is actually collapsible. And if it is collapsible, that means the volume status of the person is low. And if it is collapsible less than 50%, and the size, which is 2.0 centimeters, for her is 2.3 centimeter, it tells me that she does not suffer from hypovolemia, with all of the caveats that surround intraoperator dependability and whether or not this is something that contributes to the etiology or not.
Thank you so much. Anna, why don't you go ahead and give us the second aliquot?
Happy to. Okay, so the patient was intubated on arrival to the emergency department, and she was started on norepinephrine for her hypotension and given some bicarbonate for her severe acidosis. A little bit more data. So she had a chest x-ray that showed her ET tube was in place. She had clear lungs, aside from an opacity that was abutting her right heart border, but there was no pneumothorax. She also had a CTA of her head that was negative, a CTPE that showed a large burden of pulmonary embolism in the lobar and segmental pulmonary arteries. And she also had significant dilatation of her right ventricle. And then she had this very dense consolidation in her right middle lobe with aspirated content present in her trachea. Her abdominal and pelvic imaging was normal, aside from just showing atherosclerosis. When she returned from the CT scanner, she had escalating pressor requirements, had to have a second pressor that was added, and then had received a little bit of fluid with some improvement in her blood pressure. I can keep going and give a little bit more information if you'd like, or I can also pause there.
I think we can pause for now.
Okay.
Dr. V, what do you think? How would your management change now that we have a PE and what looks like an aspiration pneumonia?
So this is interesting. So the CTPA CTPE, that is CT of PE protocol, CT contrast of the chest PE protocol, showing a large burden of pulmonary emboli in the lobar and segmental pulmonary arteries with dilation of the right ventricle. And when we have a PEA, we have the 5 H's and 5 T's, and that is the differential that we could get from, in order to go through and find out how to solve the mystery of not only the etiology, but the prognosis. And I'm curious, before I go, to ask the audience if there is an understanding, if somebody could share with me why we think that a PE would cause a cardiac arrest. What is the physiology? Can someone give me an explanation? And this is important because it leads to my next statement. How does a PE cause cardiac collapse? You can choose to talk, you can choose to text, you can choose to do whatever you want.
Ahmed here is raising his hand. Ahmed, you can go ahead and share.
Maybe if it's a subtle PE, it can cause cardiac arrest.
How? You're on the right path. How?
It has something to do with the electrophysiology of the heart. I don't have a clear idea about it, but I read about it before. It has to do with the cardiac electricity.
Okay, that's a good start. I will probably say that's the electric dysfunction is secondary, but initially we have Kim Jin Chen. Would you tell us your thought on text as well, if you wish?
Sorry, I mute myself. So I said that increased pulmonary artery resistance leading to increased pressure that cause making a right ventricle over too hard. So eventually the right ventricle fail.
It's almost there, and I'm going to help you cross the finish line.
Okay.
When we think about PE, we think as if it's an obstructive shock, as stated by Dr. Ujma, that blocks traffic. It doesn't need to be that. In fact, when we looked at various studies, the burden itself is not necessarily predictive of an RV failure. What is predictive is exactly what you mentioned, which is increase of the pressure. So, Ahmed, the dysfunction is pressure, not electric. And what the pressure does is, if you want a liquid to flow from point A to point B, you need to have a pressure gradient. That way it follows the path of least resistance. If your point B is lower than point A in pressure, then fluid will flow. But if your point B has a pressure that rivals or even equalizes point A, flow stops. That's one reason. The second reason is something interesting, which has been discovered and talked about in obstructive shock from PE. If we want to imagine that we have the RV and the LV together, the RV is merely a volume chamber. It's not a pressure chamber. The pressure chamber is the LV, and the LV has a muscle that is super thick because it pushes the entire blood flow into the stroke volume, into the cardiac output. The RV is very thin. It doesn't have the capacity to contract much. The LV contracts against a platform, similar to someone If I was at the gym and pushing shoulders or pushing overhead press, I need to press against the platform, which is the ground. My ground, if I'm a ventricle, is the septum. As we are contracting against the septum, it allows me to have the force to send that. If I have an RV that starts to contract as well, it starts to contract on something we share, which is the septum. And that platform is now stolen somewhat by the RV. And in the echo, we start to talk about septum ballooning. And so when the septum balloons because of RV overload, the left ventricle has a dysfunctional contraction. The stroke volume now is lower, and the pressure systemically is lower. You add to that equalization of pressures, and now you have a cardiac collapse. And this is a physiologic component of PE that we call the interventricular septum dependence. So if I am to talk about this patient and I see this, the question becomes, does the PE cause what I see this, or it doesn't? And that's when I was trying to hear the CT angiogram of the chest PE protocol. Many times I hear my residents come in and say, we found PE. Okay, you can find a red herring. That doesn't mean the red herring is the reason for your symptomatology. You actually have to explain it. And in this patient, we actually do. We have a burden of PE, but we also have a dilation of the RV, and we have the IV septum bowing, and that could cause the cardiac arrest. Had I found a subsegmental PE in this patient, it would not have explained the cardiac arrest, and I would be looking at other reasons, which is the second one. When you see an aspiration in the trachea, and that's trachea, thank you, Mario, you've been extremely wonderful. I have no idea how you kept up with us, but thank you. And so when you have aspiration contents, you ask yourself, was the aspiration causing the cardiac arrest via a component of the 5 H's and 5 T's, which is the H, and that is hypoxia? Or is it a consequence? Once the collapse happened, the gag reflex is gone, now we have an aspiration. And if in this lady, it seems as though she had a PE that caused RV failure, or as we call it, acute cor pulmonale, that led to the IV septum bowing and decreased cardiac output with equalization of pressures and cardiac collapse. Once she dropped lower and now she's horizontal, now the blood does not have to go against the gravity up to the penthouse, which is the heart and the head. Now you have a lower height, and that height is allowing the equalization of the pressures to drop. And now you have a pressure gradient, and that's why she is surviving. Why is this important? Because an obstructive shock is not treated with IV fluids. I think last week there has been a study or a review that came out specifically for PE obstructive shock with a fantastic diagram, which I'm happy to share with you, that speaks exactly about this. How is fluid managed? You should not give fluids because they're going to go into the veins, down into the IVC, which is plump and non-collapsible, into the RV, which is already overload, and causing even more RV overload. And now, even in the supine position, you will have equalization of the pressures. I hope I'm making sense, everybody.
Totally. Dr. B, that was phenomenal. Thank you so much. Anna, take us away with the third aliquot.
Absolutely. I feel like I'm learning so much listening to this. This is great. So the patient ended up receiving TPA for more definitive management of her PE when she arrived in the ICU, and was also empirically started on antibiotics. for an aspiration pneumonia. And then she was started on the cooling protocol, as was mentioned, because she had a poor neurologic exam after her arrest. She did experience improvement in the first 24 hours of her admission, and was able to be weaned down to just one pressor, but then had developed again worsening shock on her second day, with also an uptrending white blood count, and then an increase in her central venous oxygen saturation. Her antibiotics were broadened at this time to vancomycin and cefepime. And then her blood cultures, almost at exact same time, from admission, had returned positive for Klebsiella pneumoniae, which was sensitive to cefepime. While she was on these antibiotics, when she had been broadened, she actually had improved. She started to improve. Her white count came down. She completed her cooling protocol and was being rewarmed. She was starting to show signs of being awake underneath it all. She had intact brainstem reflexes, and was moving all four limbs. However, did start to experience worsening respiratory failure, hypoxic respiratory failure. And she had a repeat chest X-ray that I can show. And then also, this was followed by another CT scan of her chest. And I'd be happy to show that if you'd like. Okay.
Absolutely.
And are you going to do me like this?
Oh no, I'll give you the interpretation. It's
No. That takes the fun out of it.
I do not. Okay, perfect. Co-host now. Let's see.
In my fellowship, we used to have a trick the attending day.
Well, here's the trick the attending. So I put them in the opposite orders, but the chest X-ray was done originally, and I will admit I didn't have the original image, but so the patient has no ET tube, but this is exemplary of her pathology, and then had a CT scan, which demonstrated what we see on the left.
So taking this, knowing that this is not the focus of, so I'm going to do the 7-second read. And I'm assuming this is after admission, and the previous one was not showing any of this other than the consolidation of, okay.
Yeah.
So the chest X-ray, if you direct your attention to the right, I've learned this recently, so we don't alienate vision impaired colleagues. Instead of saying, if you see, I started to learn to say, if you direct your attention. If you direct your attention to the right panel, what you would see, pardon me, is, so now we have a X-ray. An X-ray has two colors, black and white. Black is lucency, white is opacity. When I was in your shoes, I was always intimidated by X-rays, and I couldn't know why, because it felt like I knew a lot, but I just did not know how to take it to the X-rays. Well, in fact, I just had to learn vocabulary, and it starts with basic, black and white. So I see on this X-ray a right opacity taking up the right half of the lung, and not met by something symmetric on the opposite side. The left side looks as though it is all loosened. However, behind the heart, I should be able to not see any opacity other than the heart itself, yet I see an air bronchogram in across the opacity of the heart. So that in anatomy is the lingula. Therefore, there is an opacity in the lingula, and there's an opacity of the right lung with a line that is kind of weird looking in the middle, and that's usually the fissure. So I see a line there, and I see an opacity that is pretty dense, and that's what I would call a consolidation. But most importantly, it does extend to the pleural surface, and it hides the right hemidiaphragm. We don't call it hide, we call it the silhouette sign. So it is an opacity in the right lower lobe, taking up the entire half of the right lung and silhouetting the right hemidiaphragm and the right heart border. Looking at the opposite side, which is the CAT scan, I see one slice. And in that slice, what I see is indeed, now instead of just relying on up and down, I look at the bifurcation of the airway. We see the carina. On the right, there is the right main stem. And the first one that takes off is the right upper lobe. And so we have a right lower lobe, but we have what we call a line opacity lucency. Therefore, we call that an air fluid level. That air fluid level is not happening in a clean lung, it is happening in an opacity. So this is a air fluid level of a cavity within a lung parenchyma that shows opacification that is extending to the pleura, which is showing a thickening of the pleura. In a patient like ours, this is most likely, especially if it was normal before, an abscess forming both in the lung parenchyma as well as an empyema forming into the pleura. And an empyema is mainly an abscess of the pleura and an abscess of the lung. Since we have Klebsiella pneumonia and we have an aspiration, this is most likely a gram-negative or an anaerobic. And that leads us to the question, Anna, when do you in your institution use anaerobic coverage for a person who comes in cardiac arrest with aspiration or any aspiration? When do you use anaerobic coverage? And specifically, I am talking about IV metronidazole as an antibiotic.
Yeah, we use it only in very, very selective circumstances. We use it in patients who are edentulous, so they have with very, very poor dentition. We also use it in patients that have a known bowel obstruction, and so we're worried that there's perhaps content distal to the stomach. We wouldn't really expect anaerobes to live in the stomach itself, but if we're worried about content being aspirated distal to the stomach, we'll use it. And then if we see aspiration pneumonia in somebody who's critically ill and they're immunocompromised, it's kind of that double whammy where we'll do empiric anaerobic coverage. But it's really in those selective individuals. Previously, we used to use it in patients who had alcohol use disorder, and we were concerned about there being aspiration of kind of very distal content, but that's no longer something that is part of our standard practice.
That's fantastic. I myself took a few notes of that. Do you use the time to intubation for a cardiac arrest as an indicator to start metronidazole or not?
We don't. I will have to read more about that. I was not familiar with that being a marker.
So usually if it is an immediate intubation, or if it's an in-hospital cardiac arrest because they receive oral care. So if it is in Morocco, I would not use that as an indicator because it's not protocolized like in the US. But if I have a delay, like what happens to our patient, then I would probably use metronidazole as an added for antibiotics. Or if I used, for example, piptazo, then that would cover anaerobes as well. But fantastic, thank you. So in this patient, this is actually a secondary occurrence after she got better from the cardiac arrest with some preservation of the neurological function. Now we're dealing with the aspiration itself. Some of you mentioned about the Klebsiella, and as you know, once you stop the cardiac arrest happen and you have a collapse, then whatever the stomach should be making of acid is not as good, and you can have migration of basically flora from the bowels up to the lungs, and so you can start to see flora into the lungs. In fact, this is one of the main reasons why we don't use automatically anymore PPIs in the critical care. They have to have specific indications in order not to reduce the barrier of the migration from the intestines to the lungs. Be that as it may, this is getting to be interesting. We have a proverb in Morocco talking about a band of criminals that did a bank holdup, and the proverb is say they didn't get caught doing the deed, they got caught fighting about the bounty later because they were loud. So this lady did not die from the cardiac arrest, but now she's going to die of the consequences of it. Go ahead.
Yeah, I love this. Thank you so much for the walkthrough of the CT and the chest X-ray and the interinstitutional differences. That was very interesting. Anna, could you tell us more?
Yes. So much like was just discussed, we were worried about there being a necrotizing pulmonary process, specifically an abscess. However, we were maybe a little bit early on scanning her, as she had stabilized on antibiotics. So these were continued. She did have ongoing improvement in her mentation in the following days. She was actually able to spontaneously open her eyes. She was tracking. She was following simple commands like thumbs up, thumbs down, wiggling her toes, and exhibiting more voluntary movement. So she was having some steady neurologic recovery. We were rounding, now this is 2 days after getting her CT scan, she again like kind of stabilized, and we were paged by her bedside nurse that the patient, her MAPs, or her mean arterial pressures, had dropped acutely from the 70s to 40s. Her heart rates had increased from the 80s to 130s. She was in sinus tachycardia. And then the respiratory therapist had also noted that her peak pressures on her ventilator had jumped from the 20s up to the 40s. And so we went rushing to her bedside. I can keep going, or I can pause again.
I think we can take a quick pause and see what Dr. B thinks. What are you most worried about in this acute setting? What do you think we should do next?
So in the specialty of pulmonary critical care, we use a lot of, there's a chapter for ventilator called waveform analysis, and the waves themselves of the ventilator would help me understand some of the differential. Be that as it may, increase in peak pressures by itself, I don't know if we have plateaus as well. And do we have plateau pressures as well?
I could tell you that her plateau matched the jump in peak pressure, but I don't recall off the top of my head.
So the question is, the plateau and the peak, are they both going together, or are they separated? If they're separated, it's a resistance of the airway. If they're going together, then it's a system issue. And because they're going together, it's a system issue. Therefore, the system is stiff. Either you have a pneumothorax, or you have another PE, or you have an ARDS picture that happened, or very rarely, you could have mucus plugs clogging everything. But I think I would go right now with a pneumothorax first.
Hannah, take us away.
That was our thinking as well. So when we went to evaluate her at the bedside, a couple things were done. So again, using our second stethoscope, or our point of care ultrasound, we took a look at her heart that showed ongoing right ventricular dilatation, and then she had a very underfilled left side. In doing her lung ultrasound, she had no lung sliding on the right-hand side. And then in listening with our real stethoscopes, she had absent breath sounds on the right. She actually underwent needle decompression, even in the absence of getting any chest imaging due to the high concern for attention pneumothorax, and had prompt improvement in her blood pressures and her peak and plateau pressures, and a whoosh of air, which is our kind of our like Whipple's triad of tension pneumothorax. A chest x-ray was then performed after she had been stabilized that did show she had a moderate right-sided pneumothorax. She underwent surgical chest tube placement at the bedside for evacuation of air, and then also is noted to have a lot of purulent material also evacuated from the pleural space. And once she had been stabilized, after the chest tube was placed, she went for yet another field trip to the CT scanner that demonstrated a new bronchopleural fistula. Do you want me to keep going?
I think we have a diagnosis here, the bronchopleural fistula. I would love to ask Dr. B what is a bronchopleural fistula is and how it would change your management now.
Well, so we already knew from the CAT scan you showed us that there is a bronchopleural fistula, and that is the cavity that we have. Normally, the arborescence of the pulmonary tree is connected to an interstitial tissue and alveoli. So air can only go in places where it is protected by a tent called the alveolus. Unfortunately, if you have the interstitial tissue and the alveoli destruction, all you have there left is a pleural space. And that pleural space then is connected to the air coming through the bronchus, except it was sealed by the chest wall. And sooner or later, this woman would have had a pneumothorax because she is on positive pressure. You're shoving air down a tube that is continuously being destroyed by bacteria and a cavity that is increasingly big. And eventually that cavity was going to be full of air and is going to pop. So it was an expected complication eventually. How do you treat that? You treat that by, like, first you treat the pneumothorax, which is put in a connection to the outside. You treat the reason why there was fistula in the first place, which is abscess. And the abscess is, you know, most of us think that it is to be treated with antibiotics, but if you think about it, how would antibiotics diffuse into necrotic and infected tissue? It goes everywhere else but that. So you would need to drain the abscess. If the abscess was on your skin, you can put as much antibiotic cream as you want. You have to lance it. So you lance the abscess by putting a chest tube there and draining that, but that's also temporary. You would have to eventually, once your patient is stable, go to surgery and do what we call a decortication, which is peel off the pleura that is infected and scoop out all of the necrotic tissue in order to leave only healthy tissue that eventually will scar off. Now, the bronchopleural fistula is very tough to seal. And there are complex surgeries, cardiothoracic surgeries that allow to seal it. But lately, in the past 10 years, we've been putting in a valve in the bronchus that leads to that fistula and causing atelectasis of that area so that there's no more air that feeds that space, and that space eventually you allow it 6 weeks to heal. So this is like an overview of bronchopleural fistula, causes and treatments.
Thank you, Dr. V. Anna, what was that next?
Yeah, I am just learning so much from this. This is incredible, Dr. V. Thank you for teaching me. It's always interesting to like take care of a patient in the moment and then to learn so much when you're out of that kind of panicked headspace, to really dive deep into the management of some of these things. So the patient, unfortunately, she did not do well. She developed a large hemothorax in the setting of her chest tube placement because she had had the TPA recently and then was on ongoing anticoagulation to treat her PE. She kept on having her chest tube clog off as well, because we weren't really suctioning much from her chest tube to try to help the BPF close, or reduce the risk of it worsening. She had kind of ongoing transfusion dependence, which was worsening her right ventricular failure from her PE, and ultimately just, had worsening shock that was very difficult to manage, and started to develop progressively worsened mental status. She ended up re-arresting several days later, and did achieve return of circulation with her code. However, she was having a number of bleeding complications related to her code, and her family had decided to transition her to comfort care. She ended up passing away one day later with her family at bedside.
Oh, I'm sorry, Anna. Thank you so much for sharing this patient's story with us. We will all become better clinicians and better students after it. Dr. Ruby, what are your thoughts?
My thoughts is I get to be a little bit spiritual and I take a step back and I have to see how much the person has, I call it, do they still have a body to live with? And if there are multiple organ failures, many of them are irreversible. There's a certain point of no return. And I usually call it that the patient is intent on dying. And so these are these catastrophic problems. And I go to the family it was 1 o'clock in the morning when I was talking to a family like this one. And I said, I don't say prognosis, multi-organ failure. I don't say any of that. I say, I'm sorry, let's call her Francisca. I'm sorry, Francisca, your husband is not coming home. And once they absorb that shock, I say, I am not telling you I'm giving up on him. I'm being kind, but I'm trying not to insult your intelligence by hiding the truth. He's not coming home. He does not have the body to live with. And I want to ask you your permission to not inflict upon him pain at the end of his life. We will not be giving up on him, but if he chooses to leave us, we will respect his wish. And that's how I approach the code conversation with the person. Immediately after I switch into de-guilting the family by saying, it wasn't anything you could do. These are catastrophic things that nobody could have changed. And don't tell yourself, I could have not done any of this, because we need to give him what he deserves as love. So you fought for him, and now you're going to always remember that you gave him the love that was between you and the commitment that you will always treat him if he can't treat himself. So don't feel bad about doing all that we've done, but now you at least have closure. There's nothing you could have done, but now we have to make a different decision. And I use the word flatline because if I say cardiac arrest, it's a different language registry. So I say, if he flatlines again, with your permission, I don't ask, I say, with your permission, I am not going to walk in with the paddles and break his ribs. And yes, if I don't break his ribs, I'm not doing it right. So I'm not going to do this. And for your mom, I'm not going to do this. We're going to continue taking care of her. But if she chooses to leave, we are going to respect her wish. Do you have any question for me, or have I left anything unaddressed? And that's how I ask about it.
I just wanted to say that's such a beautiful way to put it. You know, I think I struggle so much in kind of developing my my language that I use to talk about difficult things at the end of life like this with families. And it's a way of kindly, making these recommendations and using your clinical assessment to guide families to what we know is the right decision, but without doing it from like a paternalistic standpoint. But really, a lot of families I find need that permission from a clinician to get to that stage to really respect what is reasonable for family members that have experienced such incredible illness. So I just really love hearing the language you use, and these are things that I will kind of put into my brain to be able to use for other patients I care for in the future. So thank you, Dr. B.
It is my pleasure, and thank you. I do give a lecture that's called Say This, Don't Say That. And we start with everything from how to explain central lines, how to explain endotracheal intubations, how to explain septic shock, multi-organ failures, to end-of-life discussions. And I crown it with a last portion of it where I brought it to chest 2 years ago, where I called physicians, but also religious leaders in their community. So it was a critical care physician that was Christian, critical care physician that was Muslim, and critical care physician that was a rabbi. So pastor, an imam, and a rabbi, all of them are critical care. And we talked about the 10 points to take away from the 3 monotheist religions in end-of-life care in the ICU. It was absolutely, amazing to hear, so that we can serve our patients better.
Dr. B, Anna, my heart is so full right now. Thank you so much for taking the time to touch on non-clinical parts. I also love how Dr. B, whenever he's talking to me about something related to withdrawal of care, he puts it on quotes, because we never withdraw care, we just like change it or change like patients' goals. Because I want to be mindful of everyone's time, I'm going to ask Anna, what are the things that you think you would have done differently looking back, and what are your takeaways from this case?
I think Anna is having to hop to another call, so she put it on the chat.
Oh, yeah, thank you so much. And now I'm going to direct the question to Dr. B. From all these amazing teaching points and discussions that we had, if you were to highlight 2 or 3, what would they be?
I think this patient has been taken care of properly. Sometimes you see a catastrophe happening and you can't really prevent it. You just watch it. But the one thing is, if you understand physiology, which is the reason why I did pulmonary critical care and not just critical care, it was because I wanted to know specifically how to explain the physiology behind things. If I do, then I don't practice what I call reflexive medicine. I practice physiologic medicine, and that allows me to prepare my patients' families to this. If I was if scientists came and said to me, pack up your things, earthquake is happening in 5 minutes, I would joke and say, you went to school for 20 years and you gave me 5 minutes? What kind of a job is this? So if I come in and call at 2 in the morning and say, your mom just arrested again, that's not a good job. But if I tell them, unfortunately, here's what's happening with your mom, I don't think she's going home, I don't think you should, and put all of this, let them absorb it in 2 to 3 years, 2 to 3 days as she was getting sicker, they are indeed going to be prepared to live the experience of losing their mom a bit less painfully. But I think everything else was done completely appropriately. So I have nothing to say that should have been done in a different way.
Thank you so much, Dr. B. And now we're gonna go to the teaching points. Noah, take us away.
Hey everyone, that was a wonderful discussion and we went through a lot of teaching points. I'm going to be brief. So first off, we started with a cardiac arrest and we talked about the initial approach to a cardiac arrest. So some important questions you should ask: where it happened, what rhythm it is, what was the time to CPR, what was the quality of CPR, the time to return of spontaneous circulation, what is the neurological status of the patient right now, any comorbidities that we know of, and the labs, with the caveat that the labs may be the cause of the cardiac arrest or the result of it. Those questions help us with the diagnosis, the immediate management and prognosis of any cardiac arrest. After we got the exam and some initial imaging and labs, we had a POCUS of the IVC. So a POCUS of the IVC is very useful for determining the volume status of the patient, depending on the size and the collapsibility. So since her IVC was a little bit large and it did not collapse, we could infer that she was volume up. She did not need any more volume. After more imaging, we saw very large PE and with significant dilation of RV with IV septum bowing. I found this discussion simply amazing. The PE in a cardiac arrest, it can be the cause, but it can also be a red herring. In this patient, we had the physiology that supported the PE being a cause of the cardiac arrest. So we have obstruction, elevated pressures in the pulmonary system, and the flow is stopped. We also have something called interventricular septum dependency. Since the RV is trying to push, it's being overloaded, it starts to contract against the septum, and the LV also uses the same septum. So the LV now has a dysfunction, and that leads to the cardiac arrest. Another finding on the physical exam that could explain a cardiac arrest was the aspiration. In this case, it was not the cause, but it can cause complications, and that's what happened. This patient developed a lung abscess and a lung empyema. After she was getting better, we had another deterioration. She had shock on the ventilator. So when you see shock on the ventilator, you have to go and look at the waveforms. But the basic train of thought is, are the plateau and the peak going together or against? If they are going together, we have to think of stiff lungs, decreased lung compliance, like the hypertensive pneumothorax. If they are not going together, we have to think of issues with airflow, like mucus plugging, biting the tube. This patient had a pneumothorax, which was drained, and then they diagnosed her with a bronchopleural fistula. So the bronchopleural fistula is destruction of the alveoli and the interstitial tissue connecting the bronchus and the pleural space. It should be managed with drainage and posterior surgery for correction, but it's a very difficult diagnosis to manage. This patient unfortunately deteriorated and passed away. We also had an amazing discussion about code conversations. So we have to avoid medical terms, use plain language that's easily understandable by the family of the patient. We have to remember to remove guilt from the family, remind them of their love for the patient. And I just love this phrase, she did not have the body to live in. And that's all I have for today.
Wonderful, my friend. Your teaching points are always amazing. Thank you so much, Noah. Thank you, Mario, for describing. I have no idea how you kept up with us, and wonderful and humbling case, Anna. And lastly, thank you so much, Dr. B, for all the teachings. We are so grateful for you. And just 1 second of me bragging, he's also my mentor. And thank you all for keeping the chat alive and for dropping your questions. And we'll see you on another subspecialty VMR.
Thank you, everybody. I appreciate the ability to teach, and I hope you all have a wonderful day.
See you.